we're looking at the diagnostic process and talking about adaptive reasoning and all of the methods that stems from that. I would hope that adaptive reasoning is the way that everybody practices clinical reasoning. There's a whole bunch of different names for this. Not that it makes any real difference. There's adaptive decision making, flexible decision making. There's a whole bunch, and they all mean the same thing. It's a matter of being flexible enough that you can deal with any scenario that comes into your clinic, from visit to visit on the same patient or different patients coming in at different times, all with different complaints. So you're not stuck with the same method of doing this. Now, as far as methodology is concerned, we've got four main ways of reasoning. One of them's not reasoning, actually. One is pattern recognition, which is unconscious reasoning. You recognize a pattern rapidly, and you compare it with differential diagnoses. They're all subconscious. You're not consciously aware of this happening, and you generate a diagnosis from that. There's hypothetic abduction or deduction, if you want to use a wrong term for it, which is inferential reasoning. There is differential diagnosis, which actually technically is an inferential reasoning method, but we're going to separate it just for clarity on our part, where you list out a number of differential diagnoses and then positively vet them to see which ones actually fit the patient's signs and symptoms. And then lastly, there's one that isn't clinical reasoning at all, and this is structured and formulaic in the form of algorithms, guidelines, treatment-based programs, and so on. So these are the ways we're doing it. But adaptive reasoning is the ability to use any and all of these in the same session, mix and match, and change what you're thinking based on changing circumstances within that session or between sessions, keeping flexible as you possibly can. These are what I think are the most important characteristics of adaptive reasoning, at least at the point of service. There are others, of course, but I think these are the ones that are probably the most important and more encompassing. So a lot of the others fit into these. The first one is recognize the context. Understand the complexity of a case. Are there medical conditions making this an issue? Are there multiple pathologies that you're going to have to deal with? Is it a biomechanical issue? Is it not a biomechanical issue? And this will determine what method of reasoning you will select, at least initially. You may bring others in as you go, but you will bring it in. For example, a simple symptom like lateral elbow pain, you can select hypothetic abduction and use heuristic availability, or availability heuristic rather, to start you off on the road to hypothesis testing. More complicated cases like that than that, say back pain, knee pain, foot pain, there may be three different conditions going on there. So you're going to need something like an exclusionary differential diagnostic method of generating H1. But this will help you determine your approach. You need to prioritize information. Not all information is equal. Not all of it is related to what you're trying to achieve at the moment. In this case, it's diagnosis. So you should prioritize everything to do with diagnosis and preferably ignore anything that's not to do with diagnosis. So don't start thinking about treatment planning here or etiology. Just concentrate on the diagnosis. Also, not all of the information about the diagnosis is equally important either. You want the more essential parts of that diagnostic kit. What are the characteristics that make this condition that diagnosis? So prioritize, otherwise you're going to get overwhelmed with information again. And you're going to be considering stuff that really doesn't matter. You need to be able to adjust the reasoning strategies as things go wrong or get more complicated as you move through this. You're going to have to change the way you do it. You may start off with an availability heuristic and find out it's not working for you, and then you're going to have to move to exclusionary differential diagnosis or possibly inclusionary differential diagnosis. You may not be able to make a diagnosis using the standard methods, and you're going to have to do it through inclusionary differential diagnosis for the whole thing. So you need to be able to change the way you're reasoning. And you're going to have to use multiple reasoning here as well. There's no reason why you can't mix and match and use hypothetic abduction along with guidelines and algorithms. Um, thinking about guidelines, algorithms, and treatment-based classification, that type of thing, there's often contradictory evidence for these. It's less confident contradicting evidence as it is contradicting interpretations of that evidence. So you're going to have to work your way through that as well. But there can also be contradictions between your subjective and objective examination. And again, you have to try to figure out what's going on. Is this an atypical condition? Or is it a new condition you've never seen before? So you're going to have to reason through that, looking at, now you're going back to basics, looking at pathology, anatomy, and so on. So you're going to have to work your way through unfamiliar, uncharted territory. You've got to be able to adapt to patients' preferences. They may not want you doing a certain test. They may not want you doing a certain treatment. So you've got to work your way around those preferences if you possibly can. And then decision confidence. You should have confidence in your decision, and you should be able to rate that confidence in probabilities. For example, if you've got less than 70% confidence in your diagnosis, it's not a good diagnosis and you need to revisit and have another go. And if you still can't get above 70%, get a second opinion on it. Similarly, the treatment plan and the prognosis. If you haven't got a lot of confidence in them, don't start doing them. Get more confidence in them, find out more, or get somebody else to give you information. Okay? These are alternatives to adaptive reality. Some of them can be used under that framework. Some of them should never be used at all in healthcare. So looking at the first one, satisficing. It's a silly name, and I'm glad I didn't come up with it. It's actually a combination of satisfying and sufficiency. And it might as well have been called that's good enough, because that's exactly what it means. Oh, all right, yeah, that's near enough. That's good enough. And it's never good enough. It means that it's suboptimal. It'll lead to a suboptimal diagnosis, which will lead to a suboptimal treatment, and nobody's going to be happy with it. Don't do it. Have greater aspirations than that. This is basically laziness more than anything else. The opposite of that is search perfection, where you can't stop looking for a perfect solution, perfect diagnosis, perfect treatment plan, perfect treatment. Most of the time, perfection isn't required here. Utility is. So it's not that urgent, not that necessary for you to do this. It certainly isn't necessary for you to come up with a very specific diagnosis in medical conditions that may show up during your examination. It's good enough to say you think it's visceral or it's vascular or something else. You don't want to be talking about the gallbladder or pathologies of the aorta and stuff like that. So there is no need for perfection in our diagnosis whatsoever. Make it optimal, the best you can do that will result in the best treatments and the best diagnosis, not submaximal, not super maximal. Introspection is dependent on your intuition, your gut feeling, and your feelings don't come into this. Oh, I think it's probably a tennis elbow. That's not how this works. Don't do that. Use evidence, not how you feel about the thing. Parallel processing is basically pattern recognition, where you do process numerous inputs, numerous pieces of evidence, forming a pattern, numerous differential diagnoses to which you're comparing the pattern, and so on. So this is parallel processing. Excellent way of doing things if you have the expertise to do it. Structured formulated protocols. These are clinical practice guidelines, decision trees, algorithms, algorithmic flowcharts, and treatment-based classification schemes. This is somebody telling you how to do your job. The fact is, if you see two different protocols for the same condition, low back pain, for example, you'll see they don't match each other. There will be differences. And so there should be, because this is to people's interpretation. And people's interpretation is not evidence. So you've gone from evidence-based or evidence-informed to basically my interpretation of the evidence. Don't do this. Don't even do it when you're a student. Don't do it when you're a new grad. If you start depending on these things, you'll never get away from it. And you're trying to do things that you can't do. Treatment classification schemes, for example. You're trying to jam in a condition into a category so you can give it a treatment. The categories are not broad enough to look at all the nuances, variabilities, outliers of that condition. It's a really ridiculous thing to do, but it saves non-clinicians from looking stupid when they're trying to teach clinical skills, and it puts it back in the academic's pocket because this is now evidence-based practice. It isn't. It just isn't. It doesn't work terribly well neither. It'll work for the average presentation in a lot of cases, assuming that the outline, the protocol has been done correctly. But when you start looking at outliers, even marginal outliers, this is not going to work for you. Means end analysis really doesn't have a role in patient care. It's where you know what the goal is, or it shouldn't do anyway. It means that you know what the goal is going to be, and you're trying to find a pathway to that goal. It works for budgets. It probably works for writing books. But as for treating patients and making a diagnosis, it probably doesn't. And if you try to do it, you're going to end up biased all to hell here. And then finally, random decision making has absolutely no place in patient care. This is when you're trying to look at competitive sports or computer games where you want to randomize things, but it has no place in patient care. So don't start thinking just because you're stuck, you'll pick a condition and see how it goes if you treat that. If you're stuck, ask somebody. Okay, let's summarize what we've done in this presentation. We're starting with adaptive reasoning, and we can go inferential or non-inferential. The non-inferential part of adaptive reasoning is structured formulaic methods, algorithm, decision trees, clinical guidelines, and so on. The inferential includes subconscious reasoning with pattern recognition, and then hypothetic abduction, inclusionary differential diagnosis. Now, all of these can be used together, place them upon each other, under each other, next to each other, but they can all be used in the same patient assessment. If we look at, we're not going to bother with inclusionary differential diagnosis as a diagnostic method, but we'll look at hypothetic abduction instead. So and we're going to look at focused. There's not a lot of point looking at unfocused hypothetic abduction. You do whatever the hell you want to, basically. So this will generate H1. Now H1 can be based on a heuristic. Usually it's an availability heuristic. Or it can be based on a consequence. So if you've got something major that could happen if you do this wrong, then that major problem is used as your first hypothesis. So for example, motor vehicle accident, you might want to put in a high cervical fracture as the most consequential injury that the patient could come in with. If that's the case, H1 would be an undisplaced high cervical fracture. Or we can go to a different form of focused hypothetic abduction, script focused hypothetic abduction, where we generate the H1 with exclusionary differential diagnosis. So I think this just about sums up most of what we said, but we're basically coming off of adaptive reasoning, not thinking about any other type, adaptive reasoning, then inferential reasoning using hypothetic abduction or pattern recognition. An overview of the diagnostic process from making the original diagnosis to checking it with bias and error medication, and ended up with the diagnosis that we're going to use in plan treatment. So we're going to use an adaptive reasoning model or method because the other ones don't make any real sense for us at all. So we've got two methods that we can use that has any sort of system to them at all. This is hypothetic abduction and differential diagnosis. If we look at differential diagnosis first, we've got inclusionary differential diagnosis, which is positive vetting of these differentials to include in the diagnosis that we're going to be using. This is a direct diagnostic method, mostly used by physicians, not very well used by us. It's too heavy, too cumbersome, and we don't have the time for it. Exclusionary differential diagnosis, on the other hand, is you're going to eliminate the diagnosis that you've listed by a single test, possibly, or a single question, much quicker, and it's more valid, really. If you've got a highly sensitive test and it's negative, you can get rid of that diagnosis, at least provisionally. This is used for generating the hypothesis with hypothetic abduction and also for bias and error mitigation. So if we go on to the other side, hypothetic abduction, the standard method is extremely variable. It's anything but standard. So it depends on the practitioner. They can ask a few questions, they can ask loads of questions. Questions could be focused on the diagnosis or completely unfocused and just take every aspect of the patient, family life, medical history and everything else. So it's very varied. Script focused hypothetic abduction, though, is a focused method of hypothetic abduction, and it's focused on the diagnosis, and it consists of the essential illness script, basically using the essential illness script to test a hypothesis. Now, in both cases, if this works out okay, it works out to a provisional diagnosis that then has to be checked for bias. So down here, we have bias error mitigation. And we've got a number of different ways of doing this. I've not done all of them, it's just the ones that are most common. So we've got exclusionary differential diagnosis and inclusionary differential diagnosis. And they can be used to check heuristic biases, attribution, anchoring, confirmation bias. This is particularly useful when you've used an availability heuristic to make the first hypothesis. Inclusionary differential diagnosis, again, is way too cumbersome. We use exclusionary, but you may have to use inclusionary when nothing's working out for you. But if you happen to use that, chances are you're not going to get a decent diagnosis from this anyway. For confirmation bias, we can repeat back the answers to the patient and check to make sure that they agree that that's what they actually said, and it wasn't your misinterpretation or your hallucination come to that. And we can give them our interpretation of what the examination has shown us and see if they agree with that. If they don't agree with it, it doesn't necessarily mean to say we're wrong, but it must give you time and chance to pause and think about this, which is all these mitigation strategies do. They just give you a chance to sit back, go, oh, that's interesting, and have another look. You can mitigate bias and error by generating H1 by exclusionary differential diagnosis. This will get rid of all of these right up front. All of the availability biases, attribution biases, this will reduce those immediately. And this is almost certainly the way to go unless you've got a very simple diagnosis on your hands. And as far as framing is concerned, don't read any reports, documents, even the referrals, don't do that. Don't speak to anybody who's seen the patient before. Don't read letters from people who are asking you for an opinion on it. Just do a blind examination on this patient, and that will limit both framing and diagnostic momentum biases. Don't worry about prevalences and incidences. Don't worry about the base rate. This will give you a pre-examination probability, and that can bias you as well. So having done all this, these attack the provisional diagnosis. If everything works out okay, then you have the diagnosis from which you can plan treatment and the prognosis. If the provisional diagnosis isn't working out for you, you're going to have to go back and find out what you've done wrong. Is it in the diagnosis itself, the diagnostic process? Is it in the treatment planning? Is it in the execution of the treatment? Is it in the prognosis? If everything's worked out fine, and you've generated a treatment plan, you're treating it, you still continue to assess the diagnosis by seeing if it's matching the prognosis as you're treating the patient. So if the patient's responding the way you would expect them to with your treatment, that's fine. If they're not, then it's not, then you have to go back and review everything you've done.